Much everyone. It's good to see you. I'm glad everyone is healthy. Dr. Amenabar, thank you for the wonderful invitation and for the panelists. I will be talking about patient selection this evening and making the best decisions. So the disclosures can be found through our Orthopedic Academy website, none directly here. I would like to encourage everyone to try to support our Hip Preservation Society. We have a virtual conference this year, and our annual meetings will ideally resume next year. So the keys to success for patient selection involve selecting the right patient, the technical aspects, as well as post-operative. And tonight, we'd like to discuss how patient selection can influence your success. Certainly, I'd like to think about things as how we address our patients, and our patients are often young, active, and have high expectations. And I would say knowing where the pain comes from can distinguish between whether you are successful or not. I think one of the things that ensures the best outcome is understanding how to take a good history, physical exam, as well as getting the appropriate pictures, but also setting patient expectations. There was a study done several years ago which looked at patient expectations and how they affected outcomes in the world of total hip arthroplasty. And I think that these findings are appropriate based on what we look at in hip preservation. If you look here, the most important activities with male patients on the left and females on the right, what do patients really want? And this is something that Phil Noble had looked at. And if you look at the normals in our population, it's very interesting to see how the normals of males were not necessarily the normals of females. In patients that were candidates for total hip arthroplasty, interestingly, walking was most important for both of those types of patients. So I think knowing what patients' expectations are will determine your best decisions. I think the pearl, or what's most important here, is to know that patient outcomes, which is what we often publish on, do not necessarily equal patient expectations. And it's important to anticipate, understand, and deliver on these expectations. I often like to think of hip pain as being defined by what we think of as typical versus atypical hip pain. Typical hip pain often is an anterior problem. It often involves an older patient. And so oftentimes atypical pain is what has challenged us for the last 10 to 30 years regarding these younger patients that we see. I'd like to think that hip pain becomes more significant when it's lasted for at least 3 to 6 months. It can exist across the spectrum of the pelvis and involves a variety of things that may have to do with activities or the gender of the patient. The longer duration of symptoms are often correlated with worse arthritis, especially in male athletes, and worse outcomes in athletes, and this has been published. And so the question is, how long can you wait on a patient that has symptoms? And what we're finding is earlier intervention may have better outcomes. So the source of the pain can often be a challenge. Is it inside or outside the hip joint, and is a simple sprain, or is it something worse? It's very interesting how our understanding of these pathologies has evolved over time. This is a slide I used to use almost 15 years ago, but it very much tried to simplify what we talk about. And I think in our training, we still emphasize these aspects. But certainly over time, what's happened is things have become more complex with regards to a lot of overlapping issues that may cause early arthritis or hip pain in our patients. The most common being mechanical in our population, including impingement and dysplasia, and on a lesser extent, trauma. I still believe and recommend that 98% of your decision should be based on a good history and physical exam. So you're oftentimes treating the patient and not their X-ray or the MRI. It's common to hear the term C sign. This was popularized by Dr. Bird, Thomas Bird, referring to a C sign, but oftentimes we look for an intra-articular diagnosis when someone presents with a C on their hip, asymmetric range of motion loss, positive intra-articular tests, and then they also have hemipelvic weakness, dysfunction, as well as radiographic findings that may be more prominent. That would be such things as an alpha angle greater than 60 degrees. An extra-articular diagnosis may be more common in a patient that has symmetric range of motion, negative provocative tests, and softer radiographic findings. It's been very popular to discuss hip instability and the question of does it exist, and we see it oftentimes in three different types of findings. The most common, or the one that we discuss the most, is traumatic. This is oftentimes seen in automobile accidents or subluxations, but we also see it in iatrogenic cases where patients have had too much bone removed during a acetabuloplasty. And then there's an emerging studies based on microinstability, patients that are either unstable because of their impingement or because of underlying collagen laxity. The idea is that sometimes hip instability is significant and sometimes it's not. The physical exam is become more formalized, but it's good to have an exam that you complement your shoulder practice with, your knee practice, and your hip is the same way. We look at inspecting the hip, palpating the joint line, range of motion symmetry, and we look at gait and lumbar flexibility in all patients. Most tests are very sensitive, they're just not very specific. Again, reinforcing the idea of symmetry on the physical exam, very, very important. When you have asymmetric motion loss, hip problems become more pronounced. This is a Faber test or a Patrick's test, and when I was in training, it was described as something to look at SI joint pathology, and I think those classic teachings have not been very supportive in our hip preservation world. We found that these types of tests may be more indicative of an intra-articular pathology versus SI joint pathology. Radiographic studies, I think, are still important. We still rely on plain films, and we'll discuss those. But oftentimes, severe arthritis may become more obvious on a plain X-ray, as well as severe dysplasia. But in our world, we try to look at having standardized X-rays to look at a variety of things. We've been trained to measure angles on our X-rays, and what we found is these angles are not necessarily representative of what we see. And so there's certainly been a paradigm shift away from completely relying on these metrics to make decisions, but they're still important. I still think that the joint space being greater than 2 millimeters is a good rule of thumb to follow. Retroversion is discussed, and this is more of becoming more of a basic concept, but the idea is to be careful not to determine retroversion if your pelvis is tilted too far forward. So looking more at an inlet view, that can become dangerous, and you can overestimate retroversion. Profunda, we try to educate people to look at different aspects of the pelvis. It's basically where the center of rotation exists inside of the hip. It's deep. And so therefore, these patients are more likely to impinge on the rim and see a pincer impingement. Some patients are very difficult to treat. And so in my experience, sometimes a hip may be too deep for a typical hip preservation procedure. And so this is an example of a Marfan's disease patient whom we did not elect to operate on because we felt that their hip was too deep for a good outcome. There's no perfect lateral X-ray, but we look at a variety of views. We look at a frog or a Dunn lateral. We also look at cross-table laterals to help us understand the offset differences. The alpha angle is oftentimes important to document, but ultimately becomes less critical when you're actually doing your dynamic test. This is a lateral view showing how you can look for secondary changes. And I would say that early on, these types of divots in the neck were underestimated as to their significance, but I would say do not underestimate the obvious on your x-rays. The false profile view has become a very important view in our practice. We look at joint space as well as coverage. Dysplasia is still sometimes more of a subjective than objective idea, but we look at Shenton's line. We also look at the coverage. And if a hip looks overtly dysplastic, it probably is and may be better served with an osteotomy. It's not unusual to have a patient referred to our practice for arthroscopy, and they will have an x-ray such as this, where they will still have joint space. And this is where the other studies can be helpful. This is the same patient with a false profile, and you can see how the loss of joint space on the false profile likely is going to contribute to it not being a good candidate for arthroscopic preservation. MRIs are good for telling us whether there's stress fractures, malignancy, or avascular necrosis. Oftentimes less successful in telling us what's going on with the cartilage. MRI arthrograms are still performed, but most of our most of our MRIs are without contrast. We oftentimes like to not use the contrast because it helps us define whether there are cysts and other pathologies around the hip. I oftentimes like to use MRI to determine whether dysplastic patients who typically have good joint space on X-ray are good candidates. And you can see here a patient with dysplastic features also has a lot of cystic change around the hip and may not be the best hip preservation candidate with our current technology. CT scans are helpful, but oftentimes you have to recognize that they are good at recognizing static anatomy, but sometimes not so much ideal for dynamic analysis. Bone scans we still use to look at things like hotspots, which would be an osteoid osteoma or a spondylolysis. The ultimate question is who is going to be the best candidate for a variety of our hip preservation technologies. We think that hip arthroscopy is still good in the skeletally mature and immature patient. This is just a list of things that it can be used for. This is an example of how treating the patient and not the X-ray is important. This is a 14-year-old patient that we treated with sickle cell anemia, and you can see the large deformation of the post-collapse femoral head in 2008, and then post-surgery, and then you can see how they remodeled in 2014. So it's very interesting how age sometimes can be a better determinant than their actual plain films. We also become creative at utilizing fluoroscopy to look at things. This is an example of a slip capitofemoral epiphysis treated with a screw, and just to be thinking about, I call this iatrogenic impingement, but how a patient's selection may be slightly out of the box thinking. Oftentimes arthroscopy is good for looking at patients who you need a definitive diagnosis. This is a patient who was 21 years old, had had pain for approximately 7 years, had not responded to an intra-articular test, and had what was determined to be the radiologist's normal studies. So the diagnostic arthroscopy was very, very helpful. Hip arthroscopy is good when you can control the patient as well as you yourself as the surgeon. Contraindications most of the time have to do with shape and orientation of the bone, too much osteoarthritis, or the patient is a poor surgical candidate. I believe the PAO, as defined by the Swiss group and GANS, is best in patients where you can offer them at least 5 years of relief with minimal arthritis. Arthroplasty of the hip is still a wonderful operation, and it seems to do best in patients who want the 90% outcome, or they've got too much arthritis on their films. So the take-home message is hip arthroscopy is best indicated for patients with hip pain that's gone on for approximately 3 to 6 months, but not too long. They have motion loss in their hip, they're losing strength and coordination, and pain with provocative tests, and no evidence of significant radiographic arthritis. So I appreciate your time this evening, and I look forward to the talks from the other panelists in our discussion. Muchas gracias.